On this episode of Back and Brew, I'm really excited to have not only a decorated, extremely great spine surgeon, but also one of my closest friends, Dr. David Mann. We're going to talk all things from healthcare to the systems of healthcare and his journey as well. This is Back and Brew. Dude, thanks for coming on. I feel like we're sitting at some table drinking this drink fairly regularly anyway. But it is Back and Brew. What did you bring?
Yeah, Chandler, thanks for having me. This is one of my all-time favorite beers. It's a East Coast IPA. It's called the Heady Topper. It's from a small brewery in Vermont. Holds a special place in my heart. Growing up, one of my college roommates' family used to vacation in Vermont, and this used to be a beer that you couldn't get unless you were willing to physically drive all the way up to Vermont and go to the brewery. And so it was always a special occasion when they would bring it back. And now they're finally distributing it pretty widely, so you can actually find it maybe once a quarter here in Colorado. And it's a fantastic East Coast IPA. At one point, it was ranked the fourth best beer in the world. So
I didn't know that.
Happy to share it with you.
Huh. What is and you've been to the brewery?
I actually haven't. I've been to some of the other kind of classic East Coast IPA breweries. Like I've been to Treehouse Brewing Company and been to Lawson's, but I've never been to Alchemist.
Yeah, this is always the one that I feel like every barbecue, we know that one of our friends is going to bring over, Marissa's going to bring carrot cake. I'm going to be grilling something, and there's going to be a 4-pack of Heady Topper brought in from Dave that he happened to get last week when the shipment came in do you get it at Argonaut, or where do you get it?
That's the secret. I don't want to ruin it, but there's a rotation in Denver. They come in on different days of the week at different places, and I've gotten it down now. So when it actually comes in, I'll go on a Wednesday to one particular place and get a case from there, and then when it comes in on Friday at a different place, I'll go get a case from there and just stock the fridge. So
it's almost weaponized autism, is what that is. Fair. Well, without further ado, man. Cheers. Cheers. The cool thing about Heady Topper is I was never an IPA guy, and Sip of Sunshine and Heady Topper are two that are extremely approachable. Heady Topper's heavier, but it also doesn't have it can kind of warm someone up to the IPA taste, especially since it's a double IPA, right?
Yeah, I don't know if anyone would call them approachable. They're 8% beers.
Well, I mean, it doesn't taste like you're drinking it through a sock, right? If it was whiskey, this would not be Lafroig. It would not be.
That's definitely true. I think that, all the East Coast IPAs, the real classic ones, have this really floral aspect to the hops, and they're really pine forward, and they're just really refreshing, easy sipping IPAs. So
yeah. It's interesting to see all these just small breweries that are popping up outside of Colorado. So Colorado was always kind of there's a brewery everywhere you go.
Yeah.
And now a bunch of them are shutting down like crazy. But then you see these things we started to see, Sculpin. You get Heady Topper from the Alchemist. You get Dogfish Head, and you start getting all these things from outside. And it's cool to see because it's someone that focuses on a craft, and they're doing the opposite of trying to fit in. And that's what's there are some really interesting parallels to this and even private practice spine surgery.
Sure.
In that your goal isn't necessarily to fit in,
Well, I think, both spaces, there's so much innovation, but to your point too, I mean, I think the quality of average care that's being delivered has come up so much. Over the years, the technology has just gotten so good in terms of what we have at our disposal in the OR, all the fun toys that we get to play with, and just the instrumentation itself, is so much more sophisticated than what it was 10 years ago. And it's the same thing on the brewery side. It used to be that you had to go to a place like Alchemist to get really, top-notch microbrews, and now you can just walk down the street anywhere in Colorado or any state for that matter and find, a dozen or more places that brew really, competitive beers. So
have you ever found an IPA that you liked that you're this is really good compared to every other IPA, not just for the area, that's from a hot area like the South?
I haven't tried too many Southern IPAs, honestly, but the year that I lived in Minneapolis for a year and working at the university there, and I was really impressed with the brewery scene in the Twin Cities. Some of the best IPAs are from the Midwest, and I was shocked how great the beer culture is there. which I guess I shouldn't have been since it's technically the grain belt, but the brewery scene there was just phenomenal, and currently one of the best IPAs in the country. It's from Surly in Minneapolis.
Huh. Yeah, and can you buy it here?
Yeah, you can find it.
Pretty much everywhere.
Yeah, they'll distribute the regular one. You can get the Axeman, which is their flagship IPA. It's fantastic. But they did special releases a couple times a year. You get like a double Axeman, and it was their double IPA, and that was the one to get.
Interesting. Huh. I'll have to try it. You were talking about Minneapolis and your time you spent there. I kind of want to take a step back and just kind of give me a rundown of like where you came from, what got you into spot to be like, you know what, I'm gonna be a neurosurgeon, and then just give me the rundown of like what the last 5 years have been.
Yeah. Well, I mean, I grew up in Princeton, New Jersey, probably about 5 minutes from the university. Grew up in a medical household. Parents are both doctors, and that's, you know, probably why I chose neurosurgery, honestly. I mean, only child, 2 doctor parents, overbearing Jewish mother, so didn't really have too much else to choose from. Grew up, spending as much time in the hospital as I did at home just because my dad worked a lot. He is a transplant nephrologist by trade, and he built the kidney and pancreas transplant program at Rutgers from the ground up. And so the way to spend time with him was to be at the hospital with him growing up. So I really grew up, in his lab, wandering the halls of Rutgers University Hospital. Fell in love with medicine early. And I think I always knew I wanted to do something within healthcare, but, neurosurgery was never even really on my radar. Honestly, I when I was probably about 13 years old, my dad was doing some heavy lifting around the house and putting in some storm windows, and felt a tear in his chest and noticed a lump. And it was firm and adherent to the chest wall. And he went and saw his doctor, and they told him it was probably a hematoma. And if it doesn't resolve in 2 weeks, that they'll ultrasound and biopsy it. So they did that. And then the biopsy came back as a liposarcoma. And, we were told that the primary tumor was almost certainly fat of the legs, that anything in the chest wall was a metastasis, and that he probably had about 6 months to live and should get his affairs in order, since they're pretty aggressive and they tend to go to the lungs pretty early. And so we took him to Memorial Sloan Kettering and MD Anderson and got opinions and got all of these thin cut CTs. And it turns out that he was the rare case where the chest wall was the primary. And so he had surgery at Sloan Kettering, followed by radiation. And he's been cancer free for, he's probably 25 plus years at this point. And so incredibly lucky. As all of that was going on, a family friend bought me Lance Armstrong's book, It's Not About the Bike, all about his cancer diagnosis. And my mom bought me my first road bike, and I started just pounding out the miles. I grew up, playing ice hockey, but I was always on the smaller side. And so cycling was an easy transition. Raced through high school, raced through college, was captain of my college's team, took a position as basically a contracted semi-pro with a team in Belgium, and then raced pretty competitively for a little while after college. Ultimately went to medical school in Philadelphia, and that's where I fell in love with neuroanatomy. We had a really great anatomist named Carson Schneck, who's, I think, read the world's first MRI, and he's been doing it forever. And he was just such a great teacher. Fell in love with the neuroanatomy. Honestly, when I went to med school, I thought I was going to do hematology and oncology because of my dad's cancer diagnosis. And I don't know, I guess I just saw the beauty in the brain, and wrestled with the decision for a long time. And I think I felt like there were probably a number of factors in it. I think, some of it was loving the anatomy, and the other parts of it were they make you choose a specialty within healthcare when you're pretty young. I had to choose what I wanted to do with the rest of my life when I was in my, mid 20s. And I think at the time I felt like I wouldn't be enough if I didn't choose what I perceived to be the most challenging undertaking within medicine.
The odd part is I've always wondered, like, and I've never asked you this, I guess, when your dad gets diagnosed with that, and there's like a certain period of unknown, and while the tests go, while you fly around to Memorial Kettering to MD Anderson, and in that amount of time, you probably are preparing and thinking, "Oh, he has months to live," because that's what they told us. What is that like? Like, how long was that period of time?
Honestly, I was pretty sheltered from it. Um, I didn't find out a lot of this until after the fact because I was pretty young. My dad got diagnosed when I was like 12 or 13 years old, and uh, my mom is from Tiberias, which is in Israel, and she moved to this country when she was 6, and she only spoke 3 words of English. And when she lived in New York, her mom had breast cancer. She was a Ashkenazi Jew, BRCA positive, and she watched her mom go through it. And her mom passed away when my mom was in her teens. And so, I think she knew how difficult that experience was. So she sheltered me from a lot of it. So I really didn't learn as much about my dad's cancer diagnosis and all of the treatment until things were much more clear that he was probably going to live for a lot longer.
That's it's always interesting too, because like like I have a fair amount of friends growing up in Western Colorado that are Mexican, right? And they're usually like second generation. Mom, dad might immigrated here,
Sure.
and they're there. To see an immigrant parent, dude, it is impressive how much their perspective is of delay comforts right now, delay feelings right now. I'm going to figure out how to get the next generation to be in a better spot than I'm in.
Yeah. I mean, I admire her work ethic as well. I mean, she's someone who came here and spoke a few words of English, like I said, and got her bachelor's, master's, and PhD all while raising me. So, yeah.
So you went to med school where?
I went to Temple University in North Philly.
Okay. And then, so to Temple, then where did you go after that?
Yeah, so I matched in neurosurgery at University of Colorado. I'm sure other people have probably come on the podcast and talked about how the process works, but it's a binding contract that you enter in with the United States government. It's basically through Medicare and Medicaid services, and it works on an economic algorithm. Basically, both parties submit the lists of where they want to end up, and this is after you spend a few months at the end of medical school, basically living out of a suitcase and flying all over the country, interviewing for the job that you want, at the programs that you want. Both parties kind of rank the each other, so the applicants rank the residency programs rank the applicants. Both parties submit their list to the national government, and then they run it through a computer algorithm and try and find you a match. And in some of the more competitive specialties like neurosurgery and plastic surgery, match rates can be as low as 50%. So there's kind of a coin flip chance of whether you're even going to be able to do what you want to do for the rest of your life. And then on match day, which usually occurs in the spring, before you graduate from medical school, everyone opens an envelope that holds their fate at usually around noon and find out where they're going to be going for the next 3 to 7 years. And it's a binding contract. So
I didn't realize it was through the government. I didn't realize it was a contract with the government. I mean, that makes sense because that's probably the cheapest form of labor too, is
yeah.
with residents.
So the government subsidizes our education. And so for each resident that a hospital has, they get a subsidy annually of like $100,000 from the government to help pay for the education and the resources that it takes to train a full-fledged doctor.
What do you make as a resident working?
It's changed a lot, honestly. The residents do so much better nowadays than when I started. I think when I started residency, which was back in 2015, my first year salary, I think, was around $48,000. And that, while I was making that, I was probably working anywhere from 80 to 120 hours a week, depending upon what rotation I was on.
So it's comparable to good union labor is what you're saying.
No, no, exactly. They do so much better now, though. Kudos to the current residents who are there. They've done a great job negotiating, and they've gotten cost of living increases, especially with Denver becoming as expensive as it is. But I think now resident starting salaries are probably closer to the 70s.
Still, for 80-hour work weeks, like 90-hour work weeks, you're like, I mean, what? Yeah, it's definitely people aren't doing it for the money to start.
Oh, definitely not. And I didn't break 70,000 as a resident until I was a chief resident. And even then, I only broke 70,000 because each chief resident gets a $2,000 bonus for doing all the admin work of organizing the call schedules. And so my salary as a PGY 7, so 15 years into my education, still working 80 hours a week, was $68,000 a year.
So if you need some good yard work done or something done around your house, go find the nearest residency program and kick them some extra bucks.
Yeah, they'd love the supplemental income. I mean, even when I was a med student in Philadelphia, sometimes I'd get in Ubers and it would be a resident working on the weekends or working on nights to supplement.
And like, what was the stuff that you would do as a resident? Because a lot of people are like, oh, it's a resident, you're just kind of following along with another doctor.
Yeah.
But what was your experience as a resident at University of Colorado in Aurora?
So I think, it varies by specialty, honestly, and it varies by training program. I think that there are some programs that people say are kind of blue collar programs. And I think University of Colorado was more of like a blue collar neurosurgery program, which is to say, they encouraged research and they wanted you to write papers and to contribute to the scientific community. But, really it was a kind of boots on the ground neurosurgery program. And there was just so much work to be done by so few residents. And so by virtue of that, you just had to be hands-on. And so, a lot of the surgeries that are done at the university are done by residents and fellows, and it's a graduated program. Obviously the most complex cases are done at the university. And so you start out early in your residency, your first year, just learning how to open and close, learning how to expose the brain safely, learning how to close when you're done working on the brain, and learning critical care, which is really a huge component of neurosurgical training, neurosurgery care that we deliver. And it was a huge part of my training at university. We had a closed neuro ICU, which meant nobody else had admitting privileges to the neuro ICU except for neurosurgery. So even when neurology or other services like trauma had to park patients in the neuro ICU, even if it wasn't for a surgical issue, even if it was just for someone who's critical from a large stroke or polytrauma but brain injured, a lot of those patients ended up on our service. And so it was the responsibility of the junior residents to deliver care to some of the sickest patients in the hospital. I still remember, first day of neurosurgery training, I showed up and it was, I think 4 or 4:30 in the morning. And I walked into the workroom and I hadn't slept all night and was so nervous about it. And the first day they slid 5 pagers across the table to me and said, "You're a neurosurgeon now, call with questions, but don't forget calling's a sign of weakness." And then everyone just scattered and went to the OR, and left me there holding the pager. And I was specifically told, 88400 is the emergency department. So if you see that number, that's a page you have to respond to immediately. And if you need help, find someone. And so I sat there staring at the pagers, and about 30 minutes into my first day, the pager went off and it was 88400 emergency department. Called them back immediately. And it was a woman who had a bad ruptured aneurysm and was found down in her front yard and unresponsive. And in those cases, we put a drain into the brain to relieve pressure. And so I had to go down to the trauma bay probably 30 minutes into being a neurosurgeon and try my hand at drilling a hole in someone's head and putting a catheter into the ventricles of their brain for a life-saving procedure. And then it only escalated from there. I think depending upon the hospital that you're at, your responsibilities are different. Understandably, there's probably a lot more hand-holding and oversight when you're doing the complex cases at the university, and there's probably more hand-holding and oversight when you're doing complex cases at Children's Hospital. But I think, when you're covering Denver Health and our trauma centers, the residents really get a lot of autonomy. It's their opportunity to do the cases sometimes by themselves because, something comes in the middle of the night, they're severely injured, waiting for an attending to get there to start a trauma cranie, would only delay patient care and worsen outcomes. And so, I had plenty of nights where I was there by myself in the middle of the night waiting for the attending to come join me at some point, but, starting the cases and being told by the attending, just make sure you're on the right side of the head,
That's pretty wild. Like, it's interesting to hear too, again, from the rep side, I'll see surgeons coming out of multiple different types of training programs.
Sure.
Neurospine, orthospine. And what's the bigger difference between even neuro and ortho spine that I see is where they came from.
Sure.
So like we've had some that have come from, really prestigious programs like an HSS or somewhere like that. And in the times I've been in cases with them, it's very clear they didn't have a huge amount of autonomy during their training. Now that you're out in the community and you see other things like that, did you ever notice that?
I mean, I think it's true. I mean, I think we're all a function of where we train, and I think everyone brings to the training their own innate abilities, and I think part of it is what you have in terms of innate three-dimensional understanding, your ability to picture the anatomy, and everyone falls on a spectrum probably in terms of what their hand-eye coordination is going to be, and I think everyone has a spectrum of where they can end up depending upon what the residency puts into them and depending upon what they put into the residency. I know, I made specific efforts during my residency to operate as much as I could. During my research year, I spent it, doing as much trauma at Denver Health and doing as many complex spine cases as doing sort of an enfolded spine fellowship. And I think that getting all of those extra reps made a huge difference. I think you look at the minimum numbers to graduate from a neurosurgery residency, and I think it's around 800 cases. When I graduated was the minimum. They may have changed it since then, but I think when I graduated from CU, I finished with around 2,200 cases or so. So, they did a great job training me, but it's also what the resident puts into the program. And so I have seen that. I mean, I think there are research heavy programs. I think it's tough too because, you go and train with a big name at some of these centers and they have a lot of wisdom and knowledge and they've innovated in the field and there's so much that they can impart on the resident. But at the same time, patients are seeking out these providers because they are, unique within the field. And so it's almost not fair to the patient if they're seeking out this person that their surgery is going to be done by someone else.
Yeah, no, I could totally see that. Would kind of break down the difference between neurospine and orthospine training for spine? Because you're a complex spine surgeon. You do a lot of huge cases. What is your perspective of like, what's the biggest delineation between those two, neurospine and orthospine?
I think, take everything I say with a grain of salt since I'm a neurosurgeon and I probably have a neurosurgical bias. The training is different. Neurosurgery is 7 years. Orthopedics is 5 years. Within orthopedics, most programs, at least from what I've seen at the University of Colorado, they spend maybe 6 months or so on a spine service. And so during their residency, they may only get, 200 cases or so of spine, if that. And I think afterwards, they then go on and do a fellowship, which is a year dedicated just to spine surgery. During that year, I think the average orthopedic spine fellow probably gets another several hundred cases during that year. I would be willing to bet probably somewhere between 200 and 400 cases. And
that are not spine specific.
That are spine specific.
That are spine specific. Okay.
During the fellowship year. And so most of them probably graduate having seen somewhere between 400 and 600 spine cases, I would guess. And I think that's probably being generous. Neurosurgery, you do 7 years. And during those 7 years, probably at least half of your education is dedicated to spine because, pathology in the spine, whether it's chronic arthritis, degenerative changes, those things occur much more frequently than we see brain tumors and aneurysms and other, more rare pathology in the brain. And so more than half of your training during your 7 years is spine. So at a busy program like University of Colorado, I think most of us graduate with well over 1,000 cases. I mean, I think I graduated with close to 1,400 spine cases when I finished my residency. And, I think one small area of frustration is that, every orthopedic surgeon who does spine gets to say that they're fellowship trained, whereas not every neurosurgeon who does spine gets to say that I've done a separate fellowship and I'm fellowship trained in this, even though, at the end of the day, you graduate with more years dedicated to spine and more spine cases under your belt. As far as the actual differences between the two go, I think each one has their strong suits. And I think that those differences in the training probably go away a lot as time goes on. I think orthopedic surgeons may have fewer numbers when they come out of their training, but that probably doesn't matter as much when you've been in practice for 5-10 years because the numbers overall are going to be fairly similar. I think neurosurgery is very good at tissue handling. And I think that we learn that by virtue of all of the other very delicate cases that we have to do constantly, whether we're in the brain or in peripheral nerves. So I think our understanding of working with those it's a strength of neurosurgeons. I also think there are some things within the realm of spine that neurosurgeons can do that orthopedics can't do, which is open the dura and operate on tumors that are in or around the spinal cord. And so I think when the dura comes into play during a spinal procedure, whether it's inadvertently from getting a tear or whether it's intentionally from doing decompressive procedures or working around the nerve roots, I think neurosurgeons probably are much more comfortable there just because that's what we do every day on a daily basis is open dura and operate on neural elements. I think traditionally neurosurgeons have been much more focused on decompression of neural elements and much more focused on that than we have been on structure and biomechanics. And I think that orthopedic spine really brought a lot to the field in terms of how they viewed hardware and instrumentation. And I think that there's a lot that we have learned from each other over the years, and the differences between the two are becoming, less major now. But I remember when I was a medical student, I was rotating at University of Pennsylvania on neurosurgery, and Chris Shaffrey came and spoke and was putting up some of his deformity cases, and there were audible gasps from the neurosurgeons in the audience because people just couldn't fathom doing a T3 to pelvis on someone. And these were just such massive cases, so much hardware. It was almost, blasphemous to the neurosurgeons. And I think over the years, the data has shown that you can actually really help people if you're selective about doing these big cases. And I think that those differences are starting to go away more. I think orthopedists are getting more comfortable working around nerves and dura, and I think neurosurgeons are getting more comfortable with these long segment fusions and thinking more about the biomechanics of the spine and not just taking pressure off the nerve.
Yeah, it's it's interesting seeing, like, again, we work with both ortho and neuro spine, and it's interesting in your cases specifically because your use of even the instruments you use for like these big deformities are instruments that we typically only see a lot of the ortho guys use, right? These big inside tube benders. Sometimes you'll use coronal benders. You'll use inside tube benders to actually reduce a rod.
Sure.
And it's really interesting. You had a very unique training, I think, partially in that you're able to kind of have a good balance of both of those, in that like you'll take out intradural tumors, but at the same time, like a T3 to pelvis, there really isn't anyone in South Denver at this point that does it as frequently or as reproducibly as you do.
Yeah, I love the big cases. I mean, it honestly, when I started neurosurgery training, I hated spine. I thought it was just something that I was going to have to do and suffer in order to be a brain surgeon. And then as the years went on, I realized that the cases I was most excited for were these big deformity cases, these big spine, fusion procedures. And I had an attending during residency who used to always say, brain surgery is like building a ship in a bottle and spine surgery is like building a treehouse. And I think there's some truth to it. Brain surgery, for as interesting and intricate as it can also be tedious at times. And I think at the end of these, marathon, long segment deformity cases, when you get the x-rays, you really can see the noticeable difference in what you've accomplished. And you can see how you've changed the alignment of the spine. And you can really get a sense of how much you've done in the last 6 to 10 hours. And I think I was really fortunate for the people that trained me and I got to work with at University of Colorado. I got to see how different people approach the same problem, which was really helpful. And I think we had two spine surgeons when I was there, and Dr. Finn and Dr. Witt, who both did long segment deformity cases and both did excellent jobs, but the way that they approached the problem was different. And I think Witt had much more of a neurosurgical background. And I think Finn did a fellowship at University of Wisconsin, which was a ortho spine fellowship. And so he approached it in much more of an ortho kind of way. And so all of those big in situ benders and, his approach was much more bring the patient to the rod. And Witt's approach was much more use expandables and other technology and custom rods and all of this to kind of make the changes in the patient less so than bring the patient to the rod. And so it's just, a different philosophy and a different way of approaching the same problem. But at the end of the day, both patients did great. So it's always, I think that's kind of the fun part about spine surgery. It's like, in the brain, the plan is generally pretty cut and dry. You've got a tumor, it's got to come out. The question is just how can you get there safely while minimizing disability to the patient, right? And in spine surgery, you could take the same MRI and series of X-rays and show it to 5 spine surgeons and get, a dozen different plans, and that's kind of the beauty of it. There's so many different ways to solve the problem.
When you, now that you're in, obviously you are 4 years into private practice, or to practice?
4 years now, yeah.
Yeah, 4 years into practice. Something that I think is really valuable that you have right now is a perspective 4 years out, right? So like a lot of spine surgeons that we'll even have on here have been in practice for 10 years or more. And it is very different starting a practice 10 years ago in Denver, and then as opposed to growing a practice in Denver, Colorado in 2025. Kind of walk me through what you think is missing in training for surgeons coming out of training and going into the workforce. I'm not even saying private practice or even hospital employed, but just them getting out into the workforce as surgeons.
Yeah, I think there's a lot of pieces that are missing in training, but I don't know that it would be great to have them as part of training, right? I mean, part of what's great about medical school and residency is that maybe this is, I don't know, naive on my part, but it's kind of the pure aspects of medicine because you're not focused on ICD codes and CPT codes. You don't have to focus on your diagnosis and billing codes. You don't have to deal with insurance companies for the most part. Patients have already largely been worked up. The surgeries have been submitted and the patients have been booked, and you kind of review the charts and you get to, in some ways, practice pure medicine. You get to show up and really just devote yourself to the care of patients. And I think that the underbelly of medicine you don't really get exposed to until you get out in the real world. And it depends what kind of jobs you take, because even then, to some degree, you're sheltered from a lot of this when you're at a major academic center. Obviously, you still have to deal with insurance companies and deal with diagnosis and billing codes, but I think, you don't have to focus as much on building a practice because a lot of people are naturally funneled into the university system. Whereas I think, Denver, like you said, has changed so much in the time that we've been here. I mean, I've been here for almost 12 years now, and Denver has grown exponentially. And I think a lot of us mistakenly think, since we're so good at delayed gratification, we're so good at focusing on studying and going to school for so many years for this, fulfillment that's going to come in our mid to late 30s. And we just expect that it's going to be there waiting for us on the other side of it. That it should be so simple as all I have to do is hang a shingle and let the world know that I'm a neurosurgeon, and people are just going to come through the door. And that's not what ends up happening. You get out there, at least I did, and I feel like when I first started, it was almost like I fell flat on my face because I just expected the work to come. And it doesn't. You really have to seek it out, especially in such a competitive market. So I think, that has been the biggest challenge, is seeing the business side of healthcare, because, physicians are notoriously bad businessmen and women.
It is funny. Like, it feels like whenever I talk to new grads coming out, that I asked you the same question. I'm like, what are you going to do to build a practice? And you told me, you're like, I'm going to have really good outcomes. I'm going to focus on being the best surgeon I can be.
Yep.
And I was like, man, it won't get you where you want to be. And it is, everyone has the same purist mentality coming out, to where it's almost like if there's a way to set the expectation in training, I'm not even saying not commit like part of the training to the business side of medicine, but just to set the expectation of your first 2 years out of training as a surgeon, you should be just trying to learn. That's it. Like, that's where your education starts in business.
Yeah.
I don't think it's ever set that way, but to be fair, the benefit of having a Peter Witt or a Mike Finn who work at the university and are somewhat to a degree sheltered from that as well, is that they do just get to focus on building you guys up and being like, here, I'm going to try to impart as much knowledge to you as I can, so you don't make some of the same mistakes I made clinically. But it seems like it's getting harder and harder, whether it be insurance companies, hospital systems, whatever it is, for a surgeon to come out of training. And like you said, they can't expect to just hang a shingle anymore.
Yeah.
It used to be that way.
Yeah. No, it did. We've talked about this many times, but the key factor for success is just time in the market. You just have to get your name out there, and for people to know you and your work and to build those relationships. And a lot of that takes time. And there's no shortcut to that. And, I think it depends on the residency program. I mean, there's some residency programs in this country, like one that comes to mind specifically, not that I know a ton about it, but is Carolina's Medical Center in North Carolina. And it's just this massive behemoth of a hospital, and they overwhelmingly do spine surgery, and those residents just operate like crazy around the clock. I don't think that they have the same burdens necessarily of covering a ICU. I think they have a lot of PA support. They have a lot of, intensivist and hospitalist support. And I think when they get out on the other side of their residency, from what I've seen, those guys are just technically very, very well trained because it's about repetitions. And I think that, every residency is going to have a bias, right? The people who trained us at University of Colorado, they specifically chose academic medicine, and that's where they want to be. They are passionate about research, and they're passionate about contributing to the scientific community. And that's great. We need those people, but, that's the perspective they're going to give you. And the reality is, we covered 4 different hospitals between Children's University Hospital, Denver Health, and the VA. And when I was there, we were a 2 resident a year program. And at any given time, you had 2 residents who were usually on research. You had 2 interns who weren't in the call pool, and you had 2 chief residents who would take chief call and weren't in the call pool. So that left us with, 8 residents to cover 4 hospitals in terms of call. And we're spread so thin, and every attending there wants coverage for their clinics and coverage for their cases, and we have to be at academic days. And I think it makes it very challenging to work other things into the curriculum. But I always thought it would be so helpful to have external rotations where a neurosurgery resident could go spend 3 months in the community and see what does private practice look like, because it's such a foreign entity when you're in training. And some training programs in different specialties, other things, do let you rotate in the community, but I had no concept of what private practice looked like. I had no concept of what community neurosurgery looked like. And I think we get a really biased view of community neurosurgery because the only times we largely interface with community neurosurgery is when we're fixing complications that get transferred to the university. So our perspective on community neurosurgeons is that they all do a terrible job and we're just stuck, cleaning up the mess. And I think that hasn't been my experience, that I've seen a lot of people out in the community who are very talented surgeons, who are very thoughtful, very gifted, and deliver comparable care to what you see in a university setting.
Yeah, no, it's interesting because for the most part, academic centers are pretty foreign to me, just because I've always just covered mainly private practice, and so it's been cool to be able to see the skill set that comes from these big, that like someone that wants to do these big complex things, to be able to do that in a community setting, which is fantastic. Which is, I think, very rare, and I think probably dying, to be fair. And I think that's probably a big push. Insurance probably pushes that to die, realistically. Coming out, talk me through the kind of cold water splash in the face when you start dealing with insurance. What was that like?
Yeah, I mean, I'm still dealing with it. Even though I think I've gotten slightly more savvy about it, I still think it's a wall we constantly are running up against. I think a lot of your documentation and how you approach patient care changes when you get into the real world. When you're documenting for purposes during residency, unless your attendings really impress upon you, a lot of it is just for the purposes of medical care. And then, unfortunately, you're forced to get out there, and you learn that even for the same surgery, if they have different, insurance providers, they're all looking for slightly different boxes for you to check in order for them to approve it. So for any given procedure that you learn how to do, whether you're submitting for that same procedure at, United or Anthem or any of these other insurance companies, they have a different list of boxes. And when you get out there, can be frustrating because at first you submit for a surgery and one insurance company approves it, and then you submit for the exact same surgery with a patient that looks the same on paper and has done all the same testing and all the same imaging and submit it to a different company, and then they deny it because they require certain special x-rays or they require more injections than the other, insurance company does in order to approve a surgery. And I think that can be challenging and frustrating. I still honestly don't fully understand the landscape of insurance companies. I mean, we had a case that we did a couple months ago, and it was approved ahead of time by insurance companies, And we did this, all day front back, 4 levels of A-lifts from the front and a minimally invasive L2 to pelvis from the back, perked everything, SI fixation, the works, huge case. And the insurance company after the fact poured through her chart and found that even though she's done extensive physiotherapy in the past, there was one box of hers that we hadn't checked. And so therefore they retroactively denied the surgery. And so we, tried to take them to collections in 4 different ways. And
The insurance company.
Yeah.
You tried to take to collections. Yeah,
correct. We tried to collect on the work that we did. And so through 4 different avenues of appeal, and it got denied every single time. And the insurance company told us to just bill the patient. And, and this was a patient who every time she came to clinic would tell me that she couldn't afford her copay. So I'd been waiving her copays the entire time. And so I'm not going to send this poor lady to collections and bankrupt her over a surgery. And so I still don't understand. I feel like you check the boxes, they approve the surgery, you do the surgery, and then they decide after the fact that they're not going to pay you for the work that you did. So to answer your question, I don't know that I fully understand insurance companies. It's just something we have to be frustrated with all the time.
What do you think the answer is? Like, where do you see healthcare going?
That's such a complex question. I don't even know where to start with that. I think insurance companies, the problem is they've kind of all congealed into these mega insurance conglomerations. And so they exert so much control over the healthcare system. And insurance companies, in some ways, or some form of that, is a necessary evil because there has to be some oversight on physicians, right? The procedures have to be indicated. I don't know what would be a better solution, submitting to a group of your peers at the hospital that you work at, whether you had a tumor board or a spine board, and you had to get the majority approval from the spine surgeons that you work with to proceed with your case. And then insurance companies have to pay for it if a consensus of, experts within the field feel that it's indicated. I have no idea. I don't know what would be a better system, but there needs to be some oversight because there are a lot of bad actors in the community, academic, outside of academics, either way, who probably are over indicating for procedures. And I think, that's the hard part in the pressure of being a surgeon, outside of the fact that you have someone's life and their functional outcomes in your hands and you want to do the technically best job for the patient that you can. There's also a lot of pressures outside of that because you have to, pay your overhead for your office. And in some ways, I didn't realize this, but taking your first private practice job is almost like reminiscent of signing a record deal, where the record company or label is going to tell you, well, we'll give you your advance, but you owe it back to the record company if you don't collect on it, right? And so a lot of these private practices will pay your salary, and it comes with a lot of negative pressure because you're incentivized to operate on everyone and to fuse everyone because you have your private practice or whatever entity dangling your income guarantee over your head, and it's going to go away at some point. And so I think there needs to be physician oversight. And I don't know what that looks like, whether it's insurance companies or another mechanism, but there has to be something to say you can't just fuse everything.
I think one of the problems too is that, like you'd mentioned, there's only a few insurance companies now. Like realistically, there's no competition.
Right.
It's United Healthcare, and then they let the other 3 realistically survive.
Right.
I'm curious how many there were. And I don't know, like 20 years ago, how many insurance companies were there, I feel like there was some competition and they'd be like, if you could go to an insurance company, be like, if you don't pay for this, I'm going to take my business elsewhere. And it could actually not even hurt them, but end up on their radar. Maybe that would help. I don't know.
Yeah. I mean, I think there's that. And I think the other problem is people don't really get much choice about insurance, right? Because it's, tied to employment, and whatever your political views on that are, it's the truth. You don't have a say in who's going to hold your insurance policy because it's whoever your work is willing to pay for.
What's interesting? I was talking to a neuromonitoring tech, and she said the only time that she can remember this year that she got paid an actual somewhat appropriate neuromonitoring fee was from like one of the small insurance companies that are like the self-funded ones. So you'll see like they'll have like Christian group, like insurance group that like it's everyone in that group like doesn't drink, has somewhat of a healthier lifestyle, and so all band together and have their own like little insurance fund. And she said she got paid exactly what she asked for in that one in like a timely fashion. And so that's what made me think like, what if there were a lot more of those that like that were affordable, that if you made healthier lifestyle choices or you weren't, you know, morbidly obese, you'd get a better rate. I just wonder, but I mean, again, whatever that group is or any of those small ones, they don't stand a chance to take on a United Healthcare, right? So they're not going to go further than these small little communities. But I'm always curious if there's like, if you could just put groups together and create these smaller, insulated insurance groups. Like what if the Seventh-day Adventists, right? It's the only blue zone we have in the U.S. where they have the most amount of centurions. Is that what it's called? Is in Loma Linda, California. And it's because it's a huge Seventh-day Adventist population. So no drinking, for the most part, no red meat. Exercise is part of their religion. Crazy. I know this is blasphemy, but what if like they had their own health insurance, you know? And you always wonder like, is that it, that you just make it smaller? Or I don't know. I don't know what it is.
I think, part of the problem with all of this though is it's a slippery slope, right? And insurance companies nowadays, they're so sophisticated, as are hospital systems. It's almost like what's happened to Major League Baseball, where they've just gotten so sophisticated with data and analysis. And it's a slippery slope, right? Like, I think it's a great thing if insurance companies are going to say, we'll lower your rate if you don't smoke, because these are preventable things. But then it's also a slippery slope where, like, what happens with your genetic data? And are you insurable because your father has a cancer history, your grandmother has a strong cardiac history? And, where do we get into the weeds on
Choices or genealogy, I guess, is what
Right.
it would be.
Right.
Yeah.
The irony in all of this too is that insurance companies, as much as they gather data on patients, also gather data on surgeons. And they have performance cards on surgeons in terms of your patient satisfaction, time with patients, your value, what procedures you perform most commonly, how you do them. I mean, they have data on everything.
I remember when the ACA brought out the idea of like patient satisfaction. Like that's what we're gonna grade a lot of surgeons on, is patient satisfaction. And like I think the saying is the road to hell is paved with good expectation or good intentions. Yeah. But like is what they saw, and I was doing spinal cord stimulators in Tennessee, and is what they saw was that the opioid epidemic came in and like really like that helped kind of throw gas on the fire of that, because what do patients consider satisfactory? How they feel. What do they need to feel better? And it was like this something that they were like, man, this is a real problem, because what do? Do I give this person the meds they're asking for, or do I risk getting dinged in a patient satisfaction survey?
Yeah, no, it created real problems when people started considering pain a vital sign. Obviously, but it's tough all around, right? Because when you're in private practice or a university setting to a lesser degree, but you're dependent upon your reputation in order to build a practice, and you do want to keep your patients happy and satisfied. But sometimes I've gotten a handful of 1-star reviews from patients, and I think honestly, if in my mind, it's a red flag if you have all 5-star reviews, because I feel like you're just catering to the patient. And sometimes it's your job to tell patients what they don't want to hear. And, I've gotten some 1-star reviews because I told patients who were seeking out surgery that I didn't think they needed surgery. And they felt that I wasn't taking their pain seriously, whereas I felt I was actually doing them a huge service, because I think they wouldn't have been happy with me if I did some huge fusion on them and they still were in horrible pain,
Do you see that in the community where some surgeons will say they'll scare people into big surgeries?
I definitely see, I think obviously the words you choose and how you choose to communicate to patients is incredibly important, right? In this country, Denver's a very educated city. Colorado's very educated in general, but, the national, literacy rates and average level that people read at is like a 6th grade level in this country. And you get, a 20 to 40-minute consultation with a patient to review their entire history of whatever's been going on with them, whether it's multiple brain tumors that have been resected in the past or a new diagnosis of a brain tumor and what that means to the patient and what their next potentially 6 months to several years are going to look like. Their whole history of spine injections and sometimes decades long history of spine surgery, back pain, and how you intend to fix this. And you have 20 to 30 minutes to explain it to them. And I think how you use language within healthcare is incredibly important. And the best doctors, in my opinion, are the ones who can take a very complicated concept and explain it to someone who doesn't have the same education as them without making them feel stupid and making them feel like they can take ownership of their own body and autonomy and procedures and how they want their healthcare managed, and make them feel like not only are they listening to you tell them what they need, but that they're at the table and an active participant in the conversation. And I think that a lot of people do use language, and I see patients for second and third opinions all the time where they've seen someone else who said, if you don't have this surgery, you're going to be paralyzed. And none of us have a crystal ball. Like, sure, you've got severe stenosis in your cervical spine, but there's probably any number of people out there who are walking down the sidewalk or driving their car who have even worse stenosis and just don't know it. And they could be one fall down a flight of stairs or one, whiplash injury from being rear-ended away from a spinal cord injury, but who can quantify what that risk is? And that's what I always tell patients. Just because you've got the findings doesn't necessarily mean that you need surgery. Every degenerated disc on an MRI doesn't need to be fixed.
Yeah, no, that's really interesting because we do hear that from patients when they get the second opinion. They're like, last person told me I was a sneeze, a car accident, a slip and fall away from paralysis. Yeah. And that's like the big thing that scares them almost into surgery. But again, I think it kind of goes back to the education piece in that there's something that I feel like the hospitals and the insurance companies try to shield the surgeons from, and that's almost the business literacy of sales. That your job, there's a huge sales component to it, and not sales in terms of you're trying to talk someone into something, but that you're trying to get over information that you think is critical to them.
Yeah.
And I feel like sales training maybe is a big part of that. And it's interesting being on the other side. I've been in med device sales for 15 years, and most of the training is how to deliver information that sticks. That's all it is. Whatever information you are trying to get over to the person, how do you have the highest chance of making it stick for the next decision-making cycle? And I'd be really interested to sit in on physicians talking to patients in year 1 compared to year 10. Yeah. I bet your conversation with patients is very different now from when you started.
Absolutely. I mean, I think all of us over time learn how we explain procedures, learn how we have the same conversation, whether it's delivering bad news about a spinal cord injury, a brain injury, delivering bad news about a new diagnosis of a glioblastoma. I mean, I think all of us have our, to some degree, canned speeches, and we adapt depending upon the dynamics of the patient and the family. But, there are certain lines that I will say more times than I can count in a day, and that have just worked their way into my repertoire when I talk to patients. And I probably say 20 times a day that I've offended many a patient by saying this, so hopefully I don't offend you, but nobody has ever died from pain, which is to say I'm not minimizing what you're going through and how much discomfort and how much it affects your life. But if we're talking about loss of neurological function, we're talking about weakness, inability to use your arms, your legs, inability to walk, that's a different story. When we're operating just for mechanical back pain, this is always elective. You don't need this surgery. Anyone who tells you you need surgery because you're in pain is just not being honest.
Totally agree with that. If you were to put rights and privileges into a bucket, where would you put pain care?
Yeah, that's, I mean, it's a complicated issue. I mean, I think everyone has the right to as pain-free of a life as they can potentially have. And so I think if they want that care, they should have access to it. But I don't think it's our job as physicians to tell them you need surgery because you're in pain. I think if they ultimately, it's our job to give them the information, let them weigh the risks and benefits, and decide how much pain they're in and whether it's worth it to them to undergo this procedure. I mean, speaking of deformity cases and doing these big complex spine revisions, part of the reason I gravitated towards that is, neurosurgery on the whole, and don't get me wrong, I love what I do. I think it's an incredible privilege to go to work every day. I think I love the nature of the procedures we do. I find them incredibly mentally stimulating. I find, I love the patient population that we take care of. I love a lot of parts of being a neurosurgeon. But there are parts of it that are disillusioning because you get out there and to our earlier point, you think you're just going to hang a shingle and the work's going to show up and it's all indicated and it's all appropriate. And that's just not the case. As I've gone through this, I at times do feel like I have to be a salesman and sell people on fusions for back pain. And part of the reason I've gravitated towards revision work is that someone else has already fused them. And at that point, the cat's kind of out of the bag and the indications are now clear. Whereas maybe the indications weren't 100% for the initial fusions, but now that they've been fused at multiple levels and now that they have flat back and adjacent segment disease and severe pain and they can't stand up straight, it's obvious that they need something substantial to fix that. And so that's why, I do some, de novo fusions in patients, but for the most part, I gravitate towards revision work because I think in those cases, the indications are clear and we're not getting subjective into, when does this make sense for axial back pain?
Yeah, no, absolutely. And it is interesting because by the time patients get to you for the big stuff, they're usually at their wit's end and they have probably more appropriate expectations, I would say, of like what they hope or maybe more appropriate aspirations.
Sure.
So I could totally see that. You use you are a technology guy. You were a professional gamer at one point. So you were a professional gamer, cyclist, and you fenced at a high level.
Yeah.
So it's funny to watch. Whenever we get something new, we carry 50 different companies. And whenever we get something new, I'm always like, oh, dude, I wonder what Dave will think about this. I got to show him. I get to hear what this is. In your mind, in spine technology, there's a lot of noise around innovation, disruption, all this stuff. And really, they'll bring out this thing that's the exact same thing as the last thing.
Sure.
What technology are you excited about and hopeful for that you think will prolong longevity or a better quality of life?
Yeah, I mean, you would laugh hearing me say this because this is very different than who I was even a few years ago when I got out of training. But I think a lot of the stuff in the motion preserving space is super cool to me. I think it makes a lot of sense. And I think you just have to be very selective about the patients that you choose to do motion preserving surgeries in, especially in the lumbar spine. I think we're much earlier in our learning curve on that. But I think that from what I've seen, if you select the right patients, people do, shockingly well with disc replacement if you're very selective about it. And I think the data is not there yet. A lot of what we extrapolate from is data within this country. Unfortunately, a lot of the European data doesn't play in, but in terms of getting devices approved. But, I think hybrid constructs are super cool options to offer patients where you can offer them the fusions where they need it and do it in a tailored way, and then also offer them motion preservation above. I think, opportunities to restore disc height and normal biomechanics before the facets become too degenerated that they need a fusion is great. I view them in some ways as almost preventative above a fusion lower down. I think that's really intriguing to me. I think other than that, our interbody technology has gotten so much better. I think that our biologics have improved dramatically. All of those things have increased fusion rates, which is great. I think our ability to deliver pedicle screws in an accurate fashion has in some ways almost peaked, right? Because if you look at the data on how good surgeons are with just an intraoperative CAT scan for navigation, it's like 98% perfect pedicle screw placement or acceptable pedicle screw placement, which is, it's hard to improve upon that. And so I think a lot of people are bringing cool innovation to the space, but again, speaking to the economics of everything and all the pressures in spine surgery, a lot of it is being done for marketing purposes more so than anything else. Like I just don't see a huge role for robotics in the spine right now in its current iteration. I understand that it's the cutting edge, and same can be said of endoscopy in the spine. I think it's a tough learning curve. Does it really offer a huge advantage over the incision that you're going to get doing it through a metrics tube, where you have a air tissue interface and you have much more degrees of freedom in how you can use your instruments? And I don't know. I mean, I think we're figuring out exactly how these new technologies are going to interface with how we currently do surgery. And I think, approaches in the spine have been really interesting to see how people are innovating. For a while, the in vogue procedures were the laterals. And I think, if you look at the long-term data, less than 15% of spine surgeons have ever adopted XLIF as a procedure. I think the pendulum always swings within spine surgery. I think we're learning now that the procedures we were doing traditionally, even though they're old procedures, are time tested, excellent procedures, and we're finding ways to do the same procedure but do it so much better. And so that's my sense on what's going on in spine. I don't really know where things are going to go from here. I mean, I think obviously endoscopy and robotics are the new, hot topics within spine surgery. But again, it's one of those things that we haven't figured out how to use. We're still so early on that learning curve. But the learning curve that I find really compelling right now is motion preservation, honestly, and especially in a hybrid sense where you can do targeted fusions where you need it, minimize the work that you have to do, prevent them from needing future spine surgery, and prevent you from marching your way up the lumbar spine, thoracolumbar spine, and that person from getting the procedures that I do love doing, which are the T10 to pelvises and the T3 to pelvises by the time they're in their 60s or 70s.
100%. It's interesting too that like you talked about like XLIF, right? So XLIF, if I would have talked to someone 6 years ago even, and I was like, hey, what's the new procedure that's going to take over? Most of them would have said XLIF. They'd be like, oh, XLIF is really interesting. And you being 38, and let's say that you have a 4-to-1 pathology.
Mm-hmm.
What do you want done?
If they can if the surgeon has a good access surgeon, I would choose ALIFs every time. I think ALIFs are phenomenal procedures. And I even say that as a 38-year-old male, because obviously the one thing we really worry about with ALIFs, especially in young men, is that any anterior spine exposure can result in retrograde ejaculation. And we have to put that on the consent. We always have to talk to them about it. Anecdotally, I've done tons of ALIF in the last however many years, and I've only had one patient who ended up with retrograde ejaculation, and it was mildly uncomfortable to him, and he's trying for a second kid now and having no fertility issues. And so even that seems like a minor, inconvenience to me. But I think, ALIFs, I'm noticing more and more are just so reproducible. I mean, I think part of the problem in choosing who's going to do what surgery on you is you don't really get a great sense for the surgeon who's going to be, opening you up and mucking around in some very, important parts of your body. And our goal should be finding procedures that are so reproducible that in the hands of any surgeon, they can do a very good job. And I think procedure that's like that is ACDF. I think anterior cervical exposures in the neck, fusions in the neck, we've been doing it for so many years and we've gotten so good at it. The hard pill to swallow is that surgeons exist on a bell curve and 50% of surgeons are below average, right? And so we need to have surgeries that can be reproduced by the bottom 50% just as well as they can by the top 50%. And I think ACDF is one of those procedures. And I'm noticing that ALIF, when you get it dialed in, is the same. It should be every single time. And I think if I had the option and a good vascular surgeon to get the spine surgeon there, I would take ALIFs.
Yeah, no, and I think we're really lucky in Colorado in general. We're in multiple states, and Colorado by far, out of all the states we're in, has the highest availability of quality access surgeons I've ever seen.
Yeah, I've been very impressed here. I think, everyone has the different vascular surgeons that they work with, and from what I've seen from everyone, they all do a phenomenal job. I've been shocked. In my training, I was always told ALIF is a 5-1, maybe a 4-5 procedure, but our vascular surgeons here have gotten me all the way up to L2, 3, sometimes L1. You know, I'm amazed how high they can get, and without difficulty. They don't even break a sweat.
Yeah, it's again, coming from in other states, we're extremely fortunate to have what we have here.
Yeah.
I always ask this question, like in deciding, what you're going to use. There's a lot of cool technology out there. In deciding between a technology or a company to use, is it the technology or the rep that's more heavily weighed on your decision?
You know, personally,
And I know it's biased because I'm sitting right here.
yeah, it's probably like 70-30, like rep technology. You know, I think every company now makes pretty good things on the market, you know, by virtue of the fact that it is such a crowded and competitive space. I mean, there's over 200 companies in this country who make pedicle screws, right? So you have to bring something good to the table if you're even going to be at the table. And so, you know, I think technology is important. Don't get me wrong. I mean, I think there are some things that are a must, like having navigation, right? It's the new standard of care for everything. You shouldn't be putting in stuff without navigation, honestly, unless you're just a fluorosurgeon and that's what you're comfortable with and that's how you were trained. That's fine. I totally understand that. But, you know, certain complex instrumentation and stuff you should always be doing with an OR. So that's the standard of care. But I think the more important thing is how you use the technology. You know, I think someone who has the most expensive TLIF cage on the market, you know, the best 3D subtracted titanium, the best nanometalling, the best, biggest aperture for fusion surfaces, the best end plate coverage, you know, the best insert and rotator, expanding mechanism, whatever the case may be, and give that to someone who does a really terrible job at disc prep, right? And just cores out a small portion of the disc, doesn't take the cartilaginous end plates, doesn't do good disc prep, doesn't do all the work that they need to do, slam that cage in there. Guaranteed they're going to have lower fusion rates than someone who has inferior technology and maybe takes an old peak inner body, but does a really good thorough discectomy and everything and prepares the graft material well and packs the disc space and gets a ton of graft in there. And, you know, I think you'd be shocked. I mean, I think how much better those patients are going to do in the long run, even though they're using a technology that's 40, 50 years older. And so I think having great technology is great and it makes you a better surgeon. But the most important things are being comfortable in the room. You know, a lot of people, and I don't think it's apt, we were joking about this the other day, compare surgeons to athletes. And it's funny, especially because you see certain surgeons and we're notoriously bad at taking care of ourselves. There was just a study that showed that amongst all doctors, surgeons have a lower lifespan than other doctors because we don't take care of ourselves. And so that's not the apt comparison, but I think the mental challenges and pushing yourself to be elite at what you do are comparable to being an athlete. You know, it's the same sort of thing where you miss a big play or drop a ball, fumble something, but you still have to get back to it and be able to wipe that away and bring the same level of intensity and focus to the next play, right? And it's the same thing in surgery. Despite our best intentions, sometimes we do drop the ball. And you have to be able to bring that same focus and intensity back to it. So I think the people that you surround yourself with in the operating room and the people that you're comfortable with and the reproducibility of it, remove variables from the table because there should be as few variables as possible so that you can deliver the best care for the person who's breathing under the drapes.
Yeah, no, it's funny. It's always funny from the sales side, seeing the sales strategy of companies. So companies used to be like, you got to show up to every single removal. Like if a surgeon is going to remove your hardware, that's your shot. You're going to get in. You're going to show them how good you are, and
Right.
then all of a sudden they're going to switch it all over. And I was new to the Denver market with a company that people only knew because of XLIF when I worked for NuVasive. And I remember I'd go to these removals, and I'm like, man, there was no epiphany made there, no matter how good I was.
Sure.
And I'm like, what I noticed is that the surgeons supported those who supported them. And
Yep.
the only way that they could really support them is just volume of cases. They're there. They know that their stuff's going to be there when they show up. That's a whole nother side of healthcare that most people don't see. Since you and I are friends, I always talk about it with you. So you have probably a bigger peek into that. But even the understanding that, hey, a manufacturer is not going to put sets and allocate resources to a surgeon in this type of hospital system because it's lower paying than other hospital systems around. So they'd just be like, yeah, we don't really want that business. But they won't say that.
Yep.
They'll be like, yeah, no, go after it. And so you'll have reps that'll commit to a surgeon. Yeah, we can have this there. And then you show up for a trauma call in the middle of the night and it's not there.
Right.
And you're like, oh, great. That's something that's somewhat newer in the last, I would say, 5 years, where it's like, yeah, the price point has gone down on all medical devices, and that's fine. But you just have to plan accordingly. And that's something that was like, that factors into younger surgeons' minds now, is availability.
Yeah.
And I'm saying that the price point goes down for those. The funny thing is, I'm telling that to someone who just got their price point reduced by 2.5% as well.
Yeah. That's unfortunately, the nature of healthcare. It is frustrating, right? Because we technically do a better job every year, and we should. The technology gets better. We get more reps. We get more experience. We have more data on how we can best treat these problems. And yet year over year, the reimbursement for the same thing becomes less than what it was, despite the cost of living going up. But that's the hard part about healthcare.
I'll go right back to it. I've said it before. The administration is what eats up the profitability in healthcare.
Yeah, no, it's absolutely true. I wouldn't necessarily want to get too much in the weeds on it, but people, I think, mistakenly think that doctors and surgeons are at the golf course driving their Lamborghini, picking money off the trees, and that's just not the case. If you look at the number of physicians that we've trained in this country, we have such a shortage in certain specialties, and it seems foreign because here in Denver, it's a very desirable place to live, and I've said this before, but I think in many ways, being a neurosurgeon and a spine surgeon, we're a luxury. We're not a necessary good, right? Even if you look at something like taking out glioblastomas, I think it's always a hard conversation to have, right? Because healthcare, whether you want to admit it or not, is a limited resource, right? There's only so much healthcare dollars that we have in the bucket per year. And it seems like a silly conversation to have because we're talking about some of these like innovations within spine hardware and instrumentation, and these things take a lot of money from the bucket. And if you look at something like taking out a glioblastoma, I mean, you need a neurosurgeon in there, a surgical microscope, navigation equipment, navigation software, multiple planning scans, MRIs, time in the ICU, radiation, chemotherapy, years, months to years of scans after that, and maybe further surgery. And every minute in the operating room is, I think, $270 a minute. In anesthesia staff and neurologists and radiation oncology and tumor boards. And, it's so many resources to bear. And if you do nothing for a GBM, the average survival is 6 months. If you do everything for a GBM, unfortunately, we haven't moved the mile markers on it too much, but it may be 18 months. But at the same time, how do you put a price on giving someone else, a year with their family, which could mean the world to them? And it's priceless. But I think that's the tough thing. And people are under this impression that physicians are just, making money hand over fist. And that's not the case. Most of us gave up our 20s and 30s and didn't really start making a decent salary until we were already way behind the 8 ball. I have so many friends who graduated from law school or master's program and started making money in their mid-20s and bought houses and invested. And I started my life when I was 36. I started my adult life, essentially. So we're so far behind as physicians. We carry a massive amount of debt. And a lot of people are under the impression that physicians are a large portion of the healthcare spending in this country, and we're just not. If you look at the whole bucket, I mean, physicians are like 6%. It's so small. And then if you look at the graph of the number of physicians, it has virtually plateaued. I mean, it's going up. It's going up very slowly. And then you look at the graph of number of healthcare administrators, and it's been exponential since the 90s.
It is interesting too, because I'll even talk to friends and I'll be like, man, the most volatile job that I know, that I've seen personally, that I've ever been in any kind of connection with, is being a spine surgeon in Denver. I'm like, really? I'm telling you, we ran through the stats of it. 70% of spine surgeons that hang a shingle in Denver will fail within their 2 years and leave the state.
Yeah.
And we've tracked it for 10 years now.
I'm not surprised. I mean, I fell within that 70%, right? I mean, my first job didn't work out for me, and I left and went back into academics in Minnesota. And fortunately, I was lucky enough to get a chance to come back since I love living in Colorado. But it doesn't surprise me. It's a really tough market.
It's interesting. People just kind of Like no one wants to hear a spine surgeon stepping out of a Porsche complaining, you know? But at the same time, everyone wants that spine surgeon to answer their call at midnight after a surgery.
Right. No, absolutely.
Yeah, it's interesting to me how like just how limited the education of spine surgery is in actual training. But man, I'm so glad you're back. It's great to have you here. Thanks for coming on.
Yeah, been a pleasure.
Heady Topper's awesome. The Alchemist makes. Have you had any of their other beers?
Focal Banger. Actually, I have some in my fridge right now.
What is it?
I'll have to bring it to you. It's another IPA.
Oh, really?
It's really good.
Just not a double IPA.
It's very similar. It's slightly lower alcohol percentage, but black can with silver and really good.
That's smart marketing.
Yeah.
Just to inverse the colors. Awesome. We'll put your website on this. So if anyone ever wanted a second opinion, which I think, and you've told me this before too, that like everyone should get a second opinion if they're recommended surgery.
Absolutely.
You're super easy to get a hold of and to be able to see that. Yeah. Thanks for coming on, man.
Thanks for having me.
Always great seeing you.
It was good seeing you too.